Hello everyone. Today I'm going to talk to you about the benefits of household data linkage in health research and how this can be used when working with NHS and other data to work out why people become sick or poorly in the first place and how people are influenced by their social and built environment, the so-called wider determinants of health. After all, people may be sick whilst in hospital, but they generally didn't get sick because they are in hospital. It's the preceding events that led to them being there. We believe that harnessing the ability of household data linkage will provide a step change in allowing providers to generate stronger evidence-based policies to improve the health and well-being of all individuals in the region. Often, analyses are made and results reported on an area-based approach, such as electoral wards. Whilst this is informative and useful in targeting resources and interventions, there is a risk that the results may wrongly attribute average population characteristics to individuals within the population, what is known as the ecological fallacy. But there are other benefits too to linking data at the household level. The population of an area isn't static, people move house. Having household linkages that are dynamic will allow cohorts of people to be created over time. When analyses are restricted to small area geographies, these do not allow the ability to check if one group of people have been replaced by another group who may be more affluent and healthier, so-called gentrification. Individual household level cohorts would allow an assessment of whether people have truly improved health as a result of service improvements, rather than simply being different people. Household linkages allow analyses to be undertaken to assess whether a change in environment impacted health, rather than it being the case that people who were more affluent chose to live in a greener and more pleasant location. This more robust evidence is liked by the Department for Health and Social Care, as it enables an examination of whether the exposure came before or after a health outcome. Household linkage also enables the construction of household groupings containing people who are likely to be members of the same family. This could, for example, enable inference of whether a child's health is impacted by that of a parent who suffers from their own health condition. A household linkage table will also allow researchers to flag only those who received a service, rather than include everyone in an area. Including everybody is a background of noise that is likely to drown out any signal of the population health benefits of a service. Analyses at the household level would therefore give evidence to help prevent services that are effective from being stopped and prioritise services more effectively. Residential linkages allow additional environmental data to be anonymised into an individual's health record. This could be additional useful explanatory variables, such as distance to travel to a GP, hospital, or community-based clinic to help understand utilisation of services. Or data could be created for the purpose of adding exposures or treatments to evaluate the population health impact of local policy changes in the wider environment. Examples include changing densities of alcohol and fast food outlets, improvements to active travel infrastructure for each household, and housing quality improvements. So, how do you go about making data linked at a household level? Well, the key to this is something called the Unique Property Reference Number, or UPRN for short. The UPRN is the unique identifier for every addressable location in the UK. You can think of it as being like a national insurance number, but for physical objects. This authoritative code can then be used to create connections between different sources of information that share a common characteristic. And that common characteristic, in this case, is the location. It is possible for people to be linked to a UPRN via their address. That address can be held, for example, in their GP data or other health and social care data. From this, it is possible to create an anonymised household identifier, meaning researchers cannot identify the house. This anonymised household identifier can then be used in conjunction with an anonymised individual linkage field that will be used to link data containing information on aspects of an individual, for example, health, social care, or education. I tell you what, why don't we have a look at a hypothetical example? Here's Joan Brown. Joan lives at number 8 Station Road in a small town in Cheshire. Joan is 72 and, according to her GP records, has chronic heart disease and had a knee replacement 3 years ago. She also gets Meals on Wheels from her local social services. And here's Lawrence Brown. He also lives at number 8 Station Road. Lawrence has diabetes and epilepsy, and he too is in receipt of Meals on Wheels. The Browns have a bus stop at the end of the road. There's a park half a mile away, which they like to go to walk the dog. And their GP surgery, which they attend quite frequently nowadays, is a little further. Now, this information is, as it stands, identifiable. We know it's Joan, we know it's Lawrence, we know the street they live in, and their house number. But when it goes through the anonymisation process, the researcher can't tell who this information comes from or which house and street it relates to. You can see here that Joan and Lawrence have different individual linkage fields. Remember, this links to their individual level data, in this case, medical and social care. They have exactly the same household identifier, though, because they live at the same property. And their environmental metrics are the same, because these also relate to their home address. Maybe the Browns would not have needed so much treatment if the GP was closer, and we can use data such as this to predict if they would have had better health if they had accessed primary care more frequently 20 years ago. Or we could use these data to show where services should be placed to avoid creating further health inequalities. Creating household linkages is quite a hard exercise to undertake, and data is often messy. However, despite it being difficult, undertaking all this is possible. And within the North West Coast, initial steps have been taken. Work's currently being done by members of the Care and Health Informatics and Improving Population Health teams as part of the System P programme to identify complex households, i.e. those where there are multiple members of the same household who are recorded as having specific health issues. Public health is about healthier environments for all, but especially for our most deprived populations who are seldom heard. And by using big data, we can ensure that they are in our analyses. We believe that only by ensuring the facility to undertake household level data linkage will it be possible to use the rich source of health, social care and other data to enable the newly created integrated care systems to deliver on their 4 key aims, namely, improving outcomes in population health and healthcare, tackling inequalities in outcomes, experience and access, enhancing productivity and value for money, and helping the NHS to support broader social and economic development.